months upon months, but yeah, everyone has different journeys to get there for sure.
Hi, everybody. Hi, welcome to PA-eShadowing. Happy Monday. Happy Labor Day, everyone. So today we have Sarah Schettle. Sarah is a cardiovascular surgery physician assistant. So thank you so much, Sarah, for coming on today, for offering all your expertise and advice to the pre-PA students. I'm sure they'll have a lot of questions. So we'll get right into it as students start to come in. So like I said, I'm going to get started, you guys. So once again, thank you, Sarah.
Of course.
Alrighty, so guys, I'm going to, of course, start by asking Sarah, how long have you been a PA?
So I've been a PA 11 years now. So it's, yeah, double digits.
Oh my gosh.
Yes.
Well, being that you've been a PA for 11 years, how has it been like, over time, especially that the PA career is a lot more popular now, like 11 years ago, not too many people knew about it. So how has it been like transitioning in time?
Yeah, it's been interesting. Initially, when I had become a PA, it was on an every 6-year cycle. Now, it's switched to kind of, every 10. So there's been different changes. The name change has recently been going through as far as how that might impact PAs. And there's been a lot. I feel like PAs have been at the forefront of change, I think, in a lot of very good ways. I think we've been able to have a little bit more authority in some of our ability to treat patients as well. Some of that can be state to state and depends on legislation, but I've been excited to be in the profession and I've loved it.
Right. That's awesome. Thank you so much. So what PA school did you go to?
I went to La Crosse, which is a PA program in Wisconsin. I think it's actually one of the smallest programs because we had about 13 people in my class.
Oh my gosh, has that changed? Do you know?
Yes, it's gotten bigger, but I think at the time it was something like, 3-to-1 or 4-to-1 student to faculty ratio. So very small, a lot of individualized, time that you had. So it was nice. You got to know all of your classmates really well, all of the faculty very well. But yeah, I mean, there's lots of great PA programs. Grew up in Wisconsin, so I was really interested in attending the La Crosse program because I knew the area. You apply for a lot of different programs, but I was fortunate that I got in there. It was my first choice. So I consider myself very fortunate to not have to have endured, cross-country treks for months upon months. But yeah, everyone has different journeys to get there for sure.
Right. So are you still in Wisconsin or did you have to move for a job or
Right. Well, I work at the Mayo Clinic now in Rochester, Minnesota. So I tell everyone I'm making incremental steps west, but not very quickly. I'm only in Minnesota so far.
Nice. So tell us about your journey to being a PA from when you decided that PA was for you, or even before that, just deciding that you want to be in healthcare, to choosing PA, to getting healthcare experience, completing your prereqs, PA school. Can you tell us more about how everything went?
Sure. When I was in high school, I know I really wanted to work in healthcare, and it's totally fine if people did not come from, a solidified, this is what I want to do, because I understand that many times people change their majors multiple times while they're, going through undergrad. But I knew I wanted to work in healthcare. I originally thought I wanted to go to medical school. So when I started as an undergrad, I was a chemistry and Spanish major with a biochem emphasis. So I had done, because I just was interested. I took Spanish when I was in high school and college, and I just it wasn't too much extra work to get a major in that in addition to getting a science related major. And I had a lot of the chemistry related classes were especially helpful for some of the medical school related things that I was working on and studying for, all of the tests and things that you have to prepare for. And so I had gone that route. And then my junior year, actually, there was a recruiter from the Madison PA program who came to our pre-med club actually and talked to us about PA, which I didn't even know being a PA was a thing, honestly, at the time. And so it seemed like a really interesting and appealing idea. At the time, I didn't really know. Everyone is different. I'm a little bit more probably type A than perhaps the average person. And so I like to have a clear set of what I want to do, where I want to go, and have the 5-year, 10-year plan, all sorted out. And I didn't really know which area I wanted to practice in medicine, but I felt like I needed to know that. I liked the flexibility that you had as a PA to say, if, I don't know, I do orthopedics for 3 years and I want to do OB-GYN, after that. And then I decide I want to do peds and then I want to do, rheumatology or something. You have that flexibility. I found that to be very appealing. And also the ability to practice a little bit sooner was also appealing to me. So I ended up switching and deciding to go the PA route a little bit later, maybe than some people decide. So I switched my junior year and I decided to go to PA school at that point. So then I applied for PA schools, in my senior year and then ended up going to PA school instead. So, yeah.
So you did not take a gap year. You went right after your senior year.
Right. Well, I actually, when I did undergrad, I was a very focused student, I guess you could say. And so I did research every single year of my undergrad. I wrote for like research grants that I had funded through the NIH and other things. Because I was really wanted to make sure I was all set for med school, that I was doing the right things, being involved in the areas that would allow me to best be prepared for that. So I think I did a lot of volunteering and work in healthcare already, just because I knew I wanted to do that. So I had already met most of the criteria that was required for PA school. So I didn't take any time off. I literally graduated from undergrad and then I think a couple weeks and then I was in PA school.
Wow, that's awesome. Mm-hmm. So would you say that being able to like easily switch specialties without like residency was like a major deciding factor when choosing PA versus MD?
I don't know that I was hopeful that I would find something that I would love right away, but in the event that I found, perhaps that I didn't enjoy that specialty or that, if you wanted to be in family practice as much, the freedom to be able to choose, I think was appealing. So not that I necessarily wanted to say, okay, I'm going to do 3 years in this and 3 years in this and just kind of like hop around all the different specialties as a PA. I didn't necessarily want to do that, but I liked that option was available to me to change if I wanted to challenge myself in a different area. I say that now that I've been 11 years in cardiovascular surgery, right? I've not switched ever. So I've been in the same role ever since I started. Mm-hmm.
Wow, I can't wait to ask you about that. Like, especially as a grad. So we're going to jump into, well, actually first, how did you get patient care experience? Did you have to for the school in Wisconsin? Or?
Yes, I had volunteered all through undergrad already, and I worked in a hospital. So I had already been doing a bunch of things just during undergrad in anticipation of applying to medical school. So a lot of at least some of those requirements are similar across the board. But for any students who are listening, I would encourage you, especially if you have particular programs in mind, all of the programs do have different requirements as far as the number of hours, even course requirements. So all of those things can be somewhat program specific. So if you really are targeting a certain program, make sure that you're aware of those particular requirements because they may not be the same from one program to the next. And you want to make sure that you're at least meeting those minimum criteria.
Right. Exactly. Mm-hmm. So we're going to move on to telling us more about PA school. So how was it like, starting, being a PA student, didactic, and then clinical year? Can you walk us through that?
Yeah, gosh, I think it's intense. Anybody who's been through PA school, I'm sure medical school is similar. You're basically getting, I think that the term that's often used is drinking from a garden hose or something like that. Basically, there's just so much information that is being thrown at you and trying to assimilate all of that information and make sense of it and then draw tangible connections amongst all those different things, because you learn anatomy and then you learn physiology and you learn pharmacology and then you realize like how these different pieces integrate. But it sometimes takes a while to pull all those pieces together because there's so much at once. So I remember it being challenging and difficult and, spending just hours upon hours and then more hours wherever I could find them to study and learn and try to get as much out of it as I could, because I thought, gosh, in 1 year, actually rotating and seeing patients. So I want to make sure that I at least feel prepared that when I come in, on the first day of a rotation, that I've at least am bringing something to the table.
Right, exactly. So what was your least and most favorite class?
Gosh, I think that whether you would ask me about least favorite classes or most favorite classes or same thing with rotations, I think that it honestly depended on the individuals teaching them. I found that the rotations I loved the most were not necessarily specialties that I thought I was going to love the most, but rather people that really were passionate about specialties and that were good teachers and that were able to take information and make it understandable. I'm a big fan of, at least in medicine, because I think we do a lot of memorizing and there certainly is a baseline level of memorization that needs to take place, but so much of medicine is understandable. And if you can take the time to understand it, then you don't have to memorize abstract concepts because they will make sense. And if you can find somebody who can teach you concepts in that way, or who can help make a rotation understandable in that way, I guarantee you will love that rotation because the pieces come together, things click. And that's something that I think is highly important. So I think, as everyone out there, goes to do rotations or, whether you're in medical school or residency, you'll learn that different people have different styles of teaching, that different people have different ways of learning. And I think it's really important for you to learn how you learn, and try to align those learning styles with somebody who can, or at least a way that you can learn from people that are able to teach you, because I think those are really important. I found that some of the classes I enjoyed the most were from individuals that really helped me understand concepts and made things understandable. So I wasn't having to memorize so much, but rather that concepts made sense. So it wasn't something that I had to say, okay, what did I memorize about this thing? But rather, okay, here's how this makes sense. And I could talk through in my head how the pieces would fit together. So it wasn't that I was memorizing information as much as connecting pieces.
Right. I didn't even think of it that way, but you are so right. Just thinking back to the classes that I didn't like, the rotations that I like, the preceptor or professor had a lot of influence on that. I didn't think, even surgery, I was not a fan of surgery, but I loved it because of my preceptor. He was amazing. So you're totally right.
Yeah. I think that often influences then what direction, you end up deciding you want to pick as a career trajectory. You end up loving a rotation because somebody made it exciting or enjoyable for you. And you're like, oh my gosh, I want to do, I don't know, pediatrics because I really had a great pediatric preceptor. Or, oh my gosh, I didn't understand pediatrics at all, and this person seemed burned out and, disengaged and, I thought I was going to like it, but I didn't. And so I think that in many ways, those can kind of influence decisions that really that affect your career. So hopefully programs are picking preceptors that, are interested and engaged and hopefully, teaching students in ways that are meaningful, because after I was done with PA school, I really had just a fantastic rotation in sports medicine and orthopedics. And I had a fantastic rotation in gastroenterology because the two preceptors I had in those areas highlighted exactly the concepts I kind of shared with you just a moment ago. And so they made it interesting and understandable. And I was an athlete, in college. I still run quite a bit now, and I swam. I did 3 sports in college. It was wild, but it was so much fun. And I liked the idea of working with athletes. So I thought, okay, I'm going to be in sports med. I'm going to be in gastroenterology. Those are the 2 things I thought I was going to do. And I said, the 3 things I'm not going to do when I'm done with PA school is anything cardiology, anything with pulmonology, or anything where I'm taking call. And now I do cardiology with call. It's the 2 of the 3 things I said were no's on my list. And I tell people it's everything I never knew I wanted to do. I've loved it, but it's not what I would have thought necessarily from the get-go. But the reason why I had thought I was going to be in those other areas was because of preceptors I had that made the experience so positive for me.
Right. Yeah, you're totally right. I thought I wanted to do OBGYN going into PA school, and then I did the rotation, and I'm like, oh my gosh, I love emergency medicine. I cannot do OB. So yeah. You're totally right. So can you tell us about how you got into cardiovascular surgery, especially as a new grad?
Sure. So I had actually received job offers from a group in the Minneapolis area and a group in the Chicago area in gastroenterology and sports medicine, because that's what I thought I wanted to do. So that's what I had applied for. And the one practice group had offered me a job, and the other one had as well. And the one had about a 2-week timeline by which I had to let them know whether or not I accepted the offer, or else they were going to offer it to another candidate. And then the other group was more of a month out there. So I thought, okay, I have 2 weeks to make this decision. And I had applied because the way that the lacrosse program worked is I had rotations at Mayo Clinic, which was kind of their collaborating partner, and then also with Gunderson Lutheran, which was another collaborating partner. And so I had at least submitted an application for a job at Mayo Clinic because I'd done rotations there, but I just hadn't heard back from their HR group. And so I thought, well, I'll just call just in case, because I think one of the unique things, there's different periods in your life where you have unique opportunities. And I think during that interview process is one of those periods of time. Take all of the interviews, you'll get a chance to see what are the different packages that people offer you, what are the financial implications of those packages, what are you getting for healthcare, what are you getting 401k or 403b matches, is there any student loan repayment, what is your overall benefits package, what are your hours going to look like, all of those things are going to be different from job to job, and being aware of that and having that time to really explore that, I think is a great thing. So if you have the opportunity to interview, maybe even if you're not super interested, but you think you might be, it may be worth considering the interview, because you might be surprised. You might end up loving the job, or maybe you'll find out that it's something you really don't want want to do, and you may learn more by doing that. So I had called HR group here and said, hey, I hadn't heard back. I submitted an application. I have to let this other group know in 2 weeks, just making sure I'm not missing anything. And then I got a call, I forget if it was later that day or the next day, by my then supervisor. And she said, we have this position available in thoracic surgery. If you're interested, you could come and interview, this week. And I thought, oh, okay. I wasn't terribly interested in thoracic surgery, but I thought, I'm not sure what Mayo necessarily offers as far as a job package, and I'd be interested to see what that might look like. So I came and I interviewed, and then partway through the interview over the lunch hour, my supervisor had a staff what was called the LVAD, the left ventricular assist device support group. And she took me with her, and I got to meet these patients, and they were just the most remarkable, resilient group of patients. And I really liked them a lot. I loved the interaction. And so after lunch, she said, we do have this position available in cardiovascular surgery, managing these, mechanical circulatory support device patients that have LVADs. And she said, is this something you'd be interested in? And I said, maybe. I wasn't sure if I wanted to do that or not, because, I wasn't sure I wanted to do cardiology, because I thought I'm a brand new, PA. Like, cardiology seems like a big deal. And I'm not sure I want to jump into something where I'm, messing with somebody's heart if I, I'm not fully ready for that quite yet. So she brought me in the next day to meet the LVAD group, the ventricular assist device group. I got to meet a couple of the surgeons, the cardiologists, the other APPs, and they were wonderful. I loved them all. And one of the best pieces of advice I think I could maybe share with students is, I think that regardless of what area you think you will like or not like, it is, in my opinion, far more important to like the people that you're working with and the environment that you're working in than the specialty. Because I guarantee you that if you work with people that are passionate about their job, that you get along with, that you enjoy working with, that you have great, administrative support, you will end up loving that role and that specialty. And if you're in a specialty that you think you love, but with coworkers that just aren't your kind of people, and you just don't quite, mesh with the group, and there's not great administrative support, you may end up hating the specialty, even though you thought you would like it. And so this was one of those where I thought, I really like the people. It's not a specialty that I thought I necessarily wanted to do, but I really liked, the people. And so so I ended up taking that job, actually, and instead of the other two jobs, because I was thinking, I'm gonna get out of a smaller town and go to, a bigger city, and then I end up in Rochester. But not Rochester, New York, or Rochester, Minnesota, which is like 120,000 people. So, but yeah, so I ended up taking the job, and I loved it. It was just a great group of people to work with. It was a lot. It was a huge learning curve, because so much of this particular space is so much of what you don't learn in PA school. Like, LVAD is like the distractor question on your pants, right? Like, you'll have one question maybe on it on the entire exam. And that's like my whole world is that, like, letter E on question 46 or whatever. That's like what I do, that area. And so so it's a really fascinating area. It's literally a specialty within a specialty, but you get to become an expert at what you do in that area. I get to help train some of the residents and the fellows. I work very closely with a cardiologist, and I get a lot of autonomy in my role. I get to do research projects. I've led research projects. I've published. I've presented nationally and internationally. I've gotten to do a lot of really unique things that I might not have been able to do had I picked a different area, perhaps an institution to have worked at. And Mayo also had a program where they, encourage people to continue to further their education. So I went back to school and got my MBA as well. So I think that really gave me a whole new perspective on really just the finances and understanding the business aspects of medicine that really isn't covered in PA school. So I think that I've had a very exciting and interesting career. I'm very interested to see where it will go in the future, but it's been fun. I've enjoyed it.
That is amazing. That is great. That's such an awesome story. And you've already dropped so many gems. I hope you guys are taking notes, because it's so awesome things. So, what's I gonna say? Okay, so can you tell us, because I've actually probably learned more about LVAD watching Grey's Anatomy than I did.
That's why my patients come. They're like, I saw this Grey's Anatomy episode, and I think there was one on maybe Chicago Fire, some other thing. I think there were two shows, because those are at least people's exposure primarily when they come. They're like, I saw it on a TV show. Okay.
Yeah, that's me. I can say I don't know much or probably anything at all. Yes. I just know the name and probably an idea based on the name. And so That's amazing that, you work in a specialty or subspecialty within a specialty. But can you tell us about like an LVAD, why a patient would need one, the type of patients? Well, because clearly, of course, guys, they're heart patients, but why does a patient end up needing an LVAD, or what is an LVAD? What does it do?
Sure. So I don't want to delve into the weeds too much here. So I'll try to make this like relatively understandable. But so when people have heart failure, sometimes people can have structural heart failure where their heart isn't functioning as it should, but they're not necessarily symptomatic yet. And then sometimes you can have both being symptomatic and having structural disease. And as that progresses, where people become more symptomatic and the underlying structural heart disease also progresses, people can reach end stage heart failure. And so if we think about our heart having, 4 chambers, you got the 2 chambers on the top, which are our atriums, and then the 2 chambers on the bottom, which are our ventricles. And the left ventricle is kind of the workhorse of the heart, or the main kind of squeezing or pumping chamber. You can think about it in that way. So on that side, you'll all learn this in PA school or med school if you go through, but there's 4 valves in the heart. There's 2 valves that let blood into the ventricles and 2 valves that let blood out of the ventricles. And so one of the valves that lets blood out of the left ventricle is called your aortic valve. So when the left ventricle squeezes, it squeezes blood out through the aortic valve to the aorta, which is your large blood vessel. It sends blood to your whole body. And so what can happen in advanced heart failure is that left ventricle squeezing capacity, or ejection fraction, can fall. So what does ejection fraction mean? I'm a big fan of like trying to make it make sense, right? So, and I'm going to try to explain the terms. So ejection is squeezing. How much are you ejecting or squeezing? So normally maybe you're somewhere in the 60 to 70% range, because your heart never fully empties. It's squeezing out most of the blood, but there's a residual amount. Just like when you breathe out, you're never breathing out all the air in your lungs. There's always a little bit of baseline air that's left. So your heart is squeezing. There's still a little bit of blood left in your heart, and maybe that's like 30%. So your heart is squeezing, maybe 60 to 70%. But over time, as you have worsened disease for a variety of reasons that we probably don't have time to get into here, that squeezing capacity reduces. So maybe you get to 50% and then 40% and 30%. To qualify for an LVAD, the Centers for Medicare and Medicaid Services, or CMS, requires that patients have an EF, or an ejection fraction, of under 25%. So essentially their squeezing capacity, or the ability for their heart to deliver blood to their body, has to be significantly reduced. In addition, they have to have a reduction in index and other things that are probably a little bit beyond the scope of this talk. But suffice it to say that these patients are very limited. They have to be class 4 heart failure, which means they're very symptomatic. At rest, they're waking up at night sometimes because they can't breathe because they're so congested because of fluid. So most of these folks already have an ICD, or a pacemaker, in place. So these are implantable devices that have little wires that go to the heart, and they can pace the heart or shock the heart if the heart is in a bad rhythm. So most all of the folks that I have ICDs. They're already on heart failure medications, and they failed those medications. They're having multiple hospitalizations, visits to you in the ED with heart failure, because they're not doing well even despite these medications. And so when they have nothing else left, then that's where I come in. So these are the most advanced heart stages of heart failure that I see. So at this point, the options for patients are either to come see me, to consider hospice and kind of end of life cares, or heart transplant, or palliative milrinone. But even then, that's something where it can make you feel better, but it's not going to prolong your life. Palliative inotropes, I should say. It doesn't have to necessarily be milrinone, but it can be any sort of an IV medication that's kind of helping your heart, but it's not something that's going to make you live longer necessarily. So if we think about it, who might be candidates for a heart transplant? Now, if you are a 75-year-old person, you're probably not going to qualify for most programs from an age criteria for an LVAD. Usually, at least at my program, typically to qualify from an age perspective, you have to be 65 or younger. And then there's other criteria, there's BMI criteria, there are substance use criteria, all sorts of other factors that are required for somebody to qualify for a heart transplant. So maybe somebody doesn't meet all of those criteria. Maybe then they're a candidate for an LVAD as just kind of a long-term support. People can get an LVAD as either like a supportive measure to get them to a heart transplant, or as a long-term rest of their life support type of thing. So then what will happen is, if they say, yep, I'm interested in getting an LVAD, and we say, we're interested in giving it to you, and they go through the workup, and we think that we're going to help more than we're going to cause harm. Because some of these folks, if you think about it, if your heart and the left side of your heart is sending blood to your aorta, which is sending blood to your body, and that is oxygenated blood, right? So if you're not getting enough oxygenated blood to your body, that includes organs, right? So we hear of like end organ failure or dysfunction. So your kidneys aren't getting enough blood, your brain isn't getting enough blood, your muscles aren't getting enough blood. So a lot of these people have what's called cardiorenal disease. Their kidneys aren't doing well, but that's because their heart isn't doing well. So sometimes if you can fix their heart, their kidneys will improve. But sometimes their kidneys are so far gone that you can fix their heart, but their kidneys are just, they've kind of given up. And so you don't want to necessarily put in an LVAD in somebody that if you create another hit to the kidney, so to speak, you're going to end up on dialysis. That would not be a good outcome because, having dialysis plus an LVAD would be really a lot for somebody to handle, much less infection risk and everything else. And so if they say, yes, we think that we're going to help somebody with this device, then the surgeon would take them to the operating room and they would either do a sternotomy, essentially an incision through your breastbone, or else they would do a lateral thoracotomy, so an incision kind of underneath the rib cage, and then they would make a hole in the apex of the left ventricle. So if you ever feel, you'll learn this in PA school, kind of where's your PMI, your point of maximal impulse. And so normally I think it's like fifth line down. All of my patients, it's so displaced because their hearts are so dilated, but where you feel that pulse, that's kind of about where they would be placing the hole in the left ventricle. So they basically core out a section of the left ventricle, and then they put in a tube in the left ventricle that's connected to a pump. And then that pump has another tube that connects to the ascending aorta. So basically, once it's turned on, blood is pulled from the left ventricle into the pump and sent to the aorta instead of the pump delivering the blood via the aortic valve to the aorta. So it's kind of a bypass of the heart. And then they have a cord that tunnels through their abdomen that exits their body. And then that cord is connected to, I tell people, kind of like a smartphone on steroids. It's like a thicker smartphone that has two batteries connected. So then we have to teach people, and then I have to know all of the different alarms. Like if it's this beep, what does that mean? If it's that beep, what does that mean? How do you change the batteries? How do you change the controller? So there's all of the peripheral things that go along with it as well. And then I do the heart failure management for them. So it's a lot, but it's exciting. I mean, during the time that I've been a PA in this area, the devices that I started with are no longer even in use. They're considered obsolete. And I've only been doing this for 11 years. So, I mean, it's great to see the technology advancing at such a fast rate in LVAD. The devices now are so much better than the devices when I started, and it's great to have new options to offer patients.
Wow, that's amazing. And you did a really great job at explaining that, by the way. You have some, I see that's a role model, amazing stories.
Oh. Well, I used to actually work in our PA program too, because Mayo started out a PA program, and I really wanted to, because I think that I've found that when people teach me in a way that's understandable, I have found that to be meaningful, and I wanted to be able to give back in that way. So I taught cardiology in the PA program, and I was on faculty there. So I did a lot of the development and rotation setup for a couple of years. And then I transitioned back into full-time practice because there was a little bit of turnover in the LVAD group. So I came back into full-time practice. So I've really dabbled in a lot of different things.
So you see, guys, the PA's career has so much variety. You can do so much as a PA.
Mm-hmm.
All right, so I have a question. Someone asked, what are the risks associated with putting a patient on an LVAD, and how do you weigh those risks as a provider? That's
an excellent question. So I usually tell people that there are different complications that come along with it. And some of those complications may be exacerbated by that patient's underlying conditions. So just at baseline, if you were to give anybody an LVAD, risks would be bleeding. So if you think about it, this pump is going to be pulling blood into it and spinning it around and sending it to the aorta. So it's going to chop up blood in a different way than your heart would. So if we think about, you've probably maybe heard of kids with hemophilia, right? So they bang their arm, they bruise really easily, and that's one of those like bleeding disorders. One of the lesser known ones is something called von Willebrand disease. So if you think about it, I like to think about, and to make it understandable, von Willebrand factor kind of like a big fluffy cotton ball. And if you send a cotton ball through your heart just sends the cotton ball around and it, goes just fine. But if you take that cotton ball and you send it through a pump, wisps of that cotton ball get tore off as it goes through the device. Think about your chemistry classes, your higher molecular weight multimers, right? Those are the pieces that are getting sheared off of that von Willebrand factor. And if you remember, if you change the shape of your protein and the structure, you change what it does, right? And so if you lose those higher molecular weight multimers, that von Willebrand factor is not going to function in the way that it did before with the loss of some of those multimers. So what does that mean? What von Willebrand factor does is it binds platelets together. So if I have this right here as a platelet and I have this as another platelet, let's say von Willebrand factor is like this, and it comes in and it binds these two platelets together. Now, if I shear off my multimers, this platelet can come over here, but this von Willebrand factor can come over here, but it can't bind these platelets together because I've lost those higher molecular weight multimers. And so platelets, if you think about it, when you cut yourself, they're the things that come up and form a scab and glom on, so you have this nice looking, scab on your arm or whatever. But if you think think about it, if you alter your von Willebrand factor, then if you're bleeding, you're going to not be able to stop bleeding as easily. And we're shearing von Willebrand factor with the pump, so bleeding risk is higher. And that's why it would make sense for it to be higher. On top of that, we put people on aspirin and warfarin. So there is a bleeding risk that exists just at baseline. Now, if somebody tells me, gosh, I've had 3 GI bleeds in the course of my history and a hemorrhagic stroke, 5 years ago, those things are going to tell me your risk of bleeding is probably higher than the average person's, if they have an underlying bleeding history. The opposite side is that clotting can be a complication in these pumps, right? So if you think about it, if you got a pump that's spinning blood around and you get a plug that or a clump of blood that plugs up that pump and that affects the pump function, the pump could stop working and you could go into heart failure. Or if that piece of that clot breaks off and blood, and it gets shoved out of the pump, it can go to your brain, right? And that could cause a stroke. It can go to your lung, it could cause a pulmonary embolism. It can go to your leg and cause a DVT. So, you kind of are weighing this bleeding and clotting risk. I always tell my patients, I'd rather you have, 10 nosebleeds, or a bleeding vessel in your intestine than 1 stroke. So we always err on the side of keeping people's INR typically between 2 and 3 to kind of mitigate that bleeding and clotting risk. So that's kind of one of the things. But if somebody says also to me, I've had, 2 ischemic strokes and, I've had, an underlying clotting disorder, those are going to affect me very much more to think I've got to anticoagulate this person much more aggressively than, somebody who maybe doesn't have those underlying conditions. Other complications can include things like right heart failure, right? So I've said LVAD a few times. I've talked about the left ventricle. I haven't talked about the right ventricle or an RVAD. There are temporary right-sided support systems that can be used, but there are no durable, long-term dischargeable RVADs that are approved for use in the United States. They are used in Europe, but not in the US. So if somebody has underlying right ventricular dysfunction and I put in an LVAD and it's something where offloading the LV is not going to kind of improve the RV, then they could have right heart failure. So those are things that we have to watch for in our evaluation, and those are risks. Somebody could still have right heart failure. They could develop right heart failure. People could develop aortic regurgitation over time. Any of those valves could start to leak. If they have underlying, regurgitation in any of those valves, maybe that's something we want to address at the time of the LVAD and maybe do a concomitant. Let's say their tricuspid valve is leaking. Maybe we do an annuloplasty at the time of LVAD so we can eliminate problems, kind of down the road. People can have infection risk, right? So if they have this cord coming out of your belly, just like if you have your pierced ear, if you tag that earring really hard and you kind of tear a little hole in your ear and then, bacteria from your skin or your finger gets in there, you can get an infection in your ear. Same thing with the cord coming out of their belly. They yank that cord, they get some bacteria in the skin. And then on top of that, how many folks do you treat in the ED that have perfectly managed diabetes? I can tell you a lot of my folks' diabetes is not that well managed, right? So you have like an overflow of glucose, which is like free food for bacteria, right? So all of a sudden you get some bacteria here and it's like, wow, party, everyone come to the source. And so you can end up with a much worse infection, So if somebody has underlying diabetes that's poorly managed, maybe their infection risk is a little bit higher than somebody who's not diabetic. So those are all things. And there's other complications that can result. Those are kind of big ones that I think about and talk with patients. But I also do a very thorough review of their past history and really kind of go into the weeds, because some of those little things end up being big things in LVAD. And so I try to weigh their underlying conditions in conjunction with what I know to be common complications of the device to hopefully present a balanced picture for the patient. I always tell them, I'm not intending to persuade you to get an LVAD or not to get an LVAD, but I want to give you the information that you need to make a decision that's right for you. Because for some people, having a mechanical pump is not consistent with their quality of life. And some people say, I want everything in the kitchen sink. Give me dialysis, LVAD, all of the, whatever it may be. And that's what they want. And so it's important to get a sense of what people want for themselves as well.
Right. So, thank you for that explanation. You have a lot of praise in the comments.
Oh, thank you.
Her passion is so inspiring. Great explanation. Amazing teacher. Thank you, Sarah.
Of course.
Someone asked, and I was wondering too, why are RVADs not used in the why are they not used in the U.S. right now?
On the right side, you mean?
Right, yeah.
I have speculations as far as maybe whether there's some cost complications in there. For people that do have biventricular support, outcomes by and large tend to be worse. So if you have a LVAD and an RVAD, outcomes generally are worse than if you just have a left ventricular assist device alone. So there's probably some element of concern that are you going to be doing more harm than good? And, is that the best way to go for somebody with that? There's other devices that you can use. We don't currently use them here. There's some centers that do something called a total artificial heart. You literally just leave atrial cuffs. You cut out the ventricles, all 4 valves. You have little atrial cuffs, and then you have these 2 plastic ventricles that are Velcroed next to each other. And then you've got these 4 artificial valves and atrial cuffs, and you sew the atria to there. And then you have 2 tubes that come out of your body with this like air pneumatic system. And so if you imagine a sphere with like a rubber diaphragm, and then if air toughs in and pushes that sphere up, that sends the blood out. And then when the air compressor like sucks the air back out, it pulls it down and blood comes into that. Those were actually around far before LVADs were. So if you ever heard of Barney Clark, probably not, because most of the people here were not. I wasn't alive when they did stuff with Barney Clark too. But some of like the first transplants were actually, people that sometimes were bridged from a total artificial heart, and they're still done. So you can do biventricular support in some contexts, but I don't know. I think that's more the Centers for Medicare and Medicaid's call that's not something that they reimburse for, and the FDA hasn't approved it. So if I get to work for the FDA, I will ask them, and I'll follow up with you in a couple of years.
Thank you. So another question, a good question is patient compliance taken into consideration when LVAD is a possible treatment plan?
Absolutely. If you have somebody who's non-compliant and you're supposed to be taking something like warfarin or Coumadin, which is a blood thinner. A little side note, warfarin was actually developed in my home state of Wisconsin. So the WARF and warfarin is for the Wisconsin Alumni Research Foundation. And then coumarin, so cows in Wisconsin, of course, the cows from Wisconsin, they were eating fermented clovers and dying because they were having actually like basically hemorrhaging internally because of this coumarin, which was basically what we know today kind of now as warfarin. So some smart guy synthesized this coumarin and used it to make rat poison. So basically that was then distributed to, anybody who was trying to get rid of rats. And then some guy later on down the road was like, if we use this in small doses and like titrate it carefully, we can use it in people to thin their blood. So imagine trying to sell that to like farmers early on, right? But yeah, so anyhow, that's warfarin, right? So if you're on a blood thinner and you need to take that daily in order to target a certain therapeutic level, and then you miss doses, and a complication of this device is clotting. And I say, I just forgot to take warfarin for a week, and then I end up with a clot in my pump, and I need to have a repeat sternotomy because my pump has failed, or I've now had an ischemic stroke because I've showered a clot to my brain. Those are very big deals. Furthermore, you have to be able to clean your dressing, or the area where the cord comes out of your belly. So if you end up with a raging infection, or if we're doing something where somebody isn't going to be able to be compliant, maybe that's not the right thing for them, because you should give people something if it's going to help them, but not if it's going to hurt them. And so if they don't have the underlying ability to be able to care for the device in a way that would allow them to succeed with it, it probably isn't best to offer that as a therapy.
Right. All right. So I'm going to answer everybody else's questions. I see a lot of questions.
Okay.
So I'll answer the general PA questions later, guys. We'll focus more on, LVAD and cardiovascular surgery right now. One question I had was, how did the coronavirus, change your practice? Like, what did it do for you working in cardiovascular surgery and with patients?
Yeah, that's a great question. I think that the unique thing is that if you end up in heart failure, it's not an elective thing. Right. You can't say, well, come back with heart failure, in another couple of months. And so we still, implanted people if they needed to, but our stable patients that we were trying to see for follow-up, we really tried to do things virtually as much as we were able. Some of the newer devices have the ability to look back a little ways into their controller to see how their numbers have trended or alarms. So that was somewhat helpful, and we we have the ability to order labs remotely, so we could still follow up on people in that way. And then we depended on people to do things like weighing themselves or taking their meds, and doing as much as we could from a remote management perspective. And some of that still continues over to today. I still do a lot of non-face-to-face visits with patients, as well as seeing them in person when we need to. So it's kind of forced us to adapt to a bit more of a hybrid practice. So I think that beauty about being a PA, right? I mean, we're adaptable. We can be in different areas. We can practice in different ways. And I think that the pandemic really forced a lot of change that would have taken, I think, health programs or institutions I would say probably at least a decade to advance this rapidly. But when you have no other choice, I think that you're able to implement change on a much more grandiose or rapid scale than you otherwise could in the absence of something like a pandemic. And so if that's the only way for you to do your job, you find a way to make it work rather than saying, well, I'd rather do it this way. So, half the people don't want to do it and the other half are, ambivalent. There were no other options. So I think we tried to find creative ways to still treat people at the level that they needed. We also carry call in my role. So, patients could still call us 24 hours a day if there were issues. So we still had, very close touches with patients, which was nice. And the nice thing is for patients that have these devices for the long-term support, I've had folks that I've known for 10 years, on device. So, at least, and that's one of the really unique things about this job is I feel like I've gotten to know so many of these patients. I know their grandchildren's names, the dog that they have, what they enjoy for hobbies. And that's really nice. And I think that it builds a level of rapport and trust that when the patient calls, they know who they're talking to. They're not talking to some random stranger or some audit system or some, call system. And I think that helps a bit too, that they know, okay, Sarah will answer and help me if I'm, dealing with something.
Right. Great question is about how many candidates do you get a year that, apply or need an LVAD versus how many are able to?
Right. It entirely depends year to year. And of course, in the midst of all of this, there was a change in the body called UNOS, which is the organ allocation system. And so a lot of patients, or I should say the distribution of patients that were supported with an LVAD is bridge to transplant versus patients that were supported with VAD for the duration of their life, changed in the context of this organ allocation change. So initially, patients that were listed for transplant were listed at status 1A, 1B, 2, or 7. And the vast majority of LVAD patients were kind of 1A or 1B, but there really was not a lot of discrimination in that 1A or 1B. And there were so many patients that were lumped in there that when everybody's an emergency, then nobody's an emergency. Like if all of your patients in the ED were all like priority 1 or whatever is your, then it'd be very hard to say, okay, what separates priority 1 from 1 from 1 from 1? Like, how do you discriminate amongst that? And so they redid the allocation system to break essentially 1A down into 1, 2, 3, and then 1B down into 4, 5, 6. So LVADs now are status 4. So in some ways has altered what people choose for bridging strategies for patients to go to transplant, because there are other ways that patients can be higher statuses, 1, 2, or 3 that are not LVAD. So the number of patients that we see in many ways is impacted by how allocation is determined. But I would say that we evaluate several patients for every patient that we ultimately select for this. Sometimes patients' underlying renal function is so poor that they don't qualify, or maybe they don't have a good support system or don't have the, ability to care for a device, or maybe, they're not interested in coming back for follow-up, or maybe they see the device and they're like, no way do I want this, so there's a lot of reasons why people may not have the ability to get a device. Our program's volume ranges from year to year. Sometimes we might have 20. I think we've had as much as almost 70. And those can also be functions of your geographical distribution. So we're kind of in the middle of a cornfield in Minnesota here. I'm not in the middle of Chicago either. So the referrals that we get are going to be different than if you're in a larger city. So those also play a role.
Okay. Thank you for that. Mm-hmm. All righty. So before we move on to, I guess, general questions, I just wanted to ask, can you walk us through like a day in the life, like from the moment you clock into work to when you clock out? You're still at work, aren't you?
I'm still at work. Yes, I'm here till 7. So
thank you so much for doing this.
No worries. I wish that I knew that something like this existed when I was trying to figure out PA school. So hopefully it'll be helpful for other people. The way that my role has changed multiple times over the years. So how it is most recently is not how it was, a year ago, is not how it was 2 years ago or 5 years ago. So currently I work 13-hour shifts. Before I worked 10-hour shifts, and before I worked 8-hour shifts. So I've worked a variety of different options. Right now,
Sorry? Is that 3 days a week because you work 13 hours? Because you work such long hours? Is it less days?
Yes, well, it just recently switched to that, literally in September. So this is, the 6th day of the new schedule shift here, and I'm also orienting a new individual to the role. So I'm picking up extra shifts just to make sure that she has a good orientation to it. So I think my schedule now is not necessarily what it will look like in the future, because I'm working mostly 4 days a week for now, just to be able to do all the pieces plus orient. But then after that, it'll probably go down to something like 3, which would end up calculating out the correct numbers. But currently, because I'm doing this orientation, which will shift, potentially in the future, I basically am doing clinic, call, and pre-op in my role. And I used to do more inpatient, but now I'm just doing this for the training purposes. So essentially, I see all of the patients that are coming to clinic for LVAD follow-up, any patients that send labs, faxes, calls, emails, portal messages, all of those come to me as well. I do all of the non-face-to-face visits, all of the scheduling of those as well. And then I also see any patients that are being referred for LVAD, for education, training on the device, ordering evaluations. And then that is technically an inpatient piece as well, because they may be in the cardiac ICU, or they could be really anywhere in the hospital. So they may have to order a bunch of preoperative measure, get them ready, order their pre-op orders, all of that stuff too. So it's a very full day.
Wow. So a student wanted to know, what are your responsibilities during the actual surgery?
So I don't actually do the surgery itself. I just prepare the patients for surgery and then do the orders, and then they actually go to the OR. So we're a training institution. So we have medical students, residents, fellows, and then our surgeon, and they all need to get in different, hours and number of cases. So they're primarily doing the OR bit. And so we don't really have PAs that do the LVAD bit in the OR.
Oh, okay.
Mm-hmm.
Cool. All righty. Let's see. When do I have any more LVAD? What was your training like for cardiovascular surgery?
So I had a 4-month orientation period to kind of go over and learn all of the different pieces, because so much of what I do is not what you learn in school. You probably didn't learn anything about LVADs really in school. And so a lot of that is on the job training to learn about all, because at the time, I think there were 5 different LVADs that were in use. So you have to know all of the different devices, all of the nuances of them, the different alarms that go with the different devices, management strategies. All of our surgeons had different preferences at the time too for antibiotics and usage. And so it was just a lot of learning for those first 4 months, just to kind of get a handle of what you're doing. But I think that really in any role, whether it's LVAD or anywhere, give yourself a good year or two to feel like you are settling into that role, because no one is going to be an expert in year one. If you think you are an expert, you're either really brilliant, or maybe you underestimate, where you're at, perhaps, because it takes a while really to get to learn how to do it. And I think that there's so much of the job that is not necessarily what you learned in school that just takes time. What are the team dynamics? How do you work with the EMR? How do you dictate if you dictate? How do you code? How do you bill? How do you interact with, there's just so many pieces that take time to learn and to get acclimated to, that are outside of what you'll learn in school. So give yourself grace. Give yourself a year or two to settle into it. If you don't love it 9 months in, that's okay. I don't think most people are like, wow, this is exactly what I thought. Give it time. It'll settle into it. And if in 2 years, you're still like, I'm just not sure that I'm loving it, then maybe at that point you say, okay, see if there's another, area that you want to transition to, or another practice perhaps. But 6 months in, I don't think anyone is saying, okay, well, if you're not an expert in 6 months, then that's it. You're never going to make it. I don't think that's a realistic expectation.
Right. So last question is, how many days are you on call?
So this again has been very much in flux. I used to be on call every 7, then I was every 5, then I was every 3. Now I'm just call while I'm at work. So it seems to be an evolving practice. Because we are a small group that knew how to manage these patients, we were taking night and weekend call all the time. So that was kind of what those numbers entailed. But now it's mostly just while I'm here that I'm call.
Okay.
Yeah, so it changes on a regular basis, it seems.
Awesome. So now we're going to move on to just general PA questions that you guys have. I see a lot of questions about MBA and a PA career. So one of the students wants to know, is this career still sustainable, or do you think the job market has become saturated in the last 10 years? I
think that if you're passionate about what you do and you can offer something to medicine, you can make a go of it as a PA. You don't necessarily even need to be a PA in a hospital per se. So there's a lot of options. If you're worried that the hospital environment is saturated, you can go into private practice. If you don't want to do private practice, you can do a lot of things on your own, and you can even use your medical training to do something that isn't necessarily medicine. You could work for industry, you could do consulting, you can start your own business. And you've started a business. You and I both have done different things outside of medicine. So there's lots of options. I think that it gives you a great great knowledge base by which to use as a springboard to pursue other things if you want to do that. And honestly, I mean, I've done a ton of research, so I could, if I wanted to, just pivot into doing research full time, or I could just decide I want to, go into operations, or I could do administration, or I could really do a lot of different things besides just PA if I wanted to. That said, I really don't think that the market would ever be saturated, because if you look at the direction that healthcare is going, there's a big push towards preventative medicine. And I think that that's where and especially in cost-effective bundled payments, PAs are going to be a much more cost-effective option than some of the other strategies that have been pursued out there. So I think that from a payer perspective and from a CMS perspective, I don't foresee the need for NPs or PAs diminishing at all in the future. I expect it to rise.
That's an awesome response, and I totally agree.
Mm-hmm.
This is a little long, but a student wanted to know, when applying for your PA program, did you have to go through an interview? If so, what kind of questions did they ask, and how did you answer? If you remember,
Yes.
It's been like 10 plus years.
Yes. No, I do actually remember a couple of the questions. Hopefully they aren't using the same questions still, so I don't want to, ruin it if that's the case, but I imagine they probably recycle them. So I remember that, and I don't know, every program is going to ask different questions, but one of the questions that they asked me was, what was a recent book I read and what did I like about it? I got another question about a recent piece of healthcare legislation that had passed, and they asked, they had done group interviews. So 3 people were all brought in at once. So you were not interviewed one-on-one. You were brought in with a faculty member and like 3 of you, and then they would ask the question and see the interactions with people and with them. So it was definitely kind of a unique, it was like a way of interviewing, and both you and also your interactions with other students. Interestingly, amongst my group, none of us had even heard of this legislation, and we had no idea. No one actually in the entire group, I think, had heard of this. I think it was a bit of obscure legislation, but it was a question. Then there was another one where they had asked the 3 of us that were in my interview group, if you all 3 were accepted into PA school, but one of you had to be accepted in year 1, one of you had to be accepted in year 2, and one of you had to be accepted in year 3. Who would be accepted in year 1, 2, and 3, and why? You have a couple minutes to discuss. So then we had to discuss it. Interestingly, all 3 people in my, and remember, we have a very small program, right? So all 3 people that were in my interview panel all got into the program. So it was like me and the other 2. Yeah, I don't know what the odds are, or if we just happen to have good chemistry or what have you, but that was a question. I think those were at least the ones that stood out, because I just remember them being more unusual, like ones that I hadn't necessarily planned on or prepared for. I did ask about the book question once I got into the program, and I said, why did you ask about that? And they said they wanted to make sure that we had interest outside of just medicine, that patients appreciate people who are people, not just somebody who is, so deep in medicine that they cannot relate to anybody outside of that. So they didn't want the last book that I read to be, I don't know, why I love anatomy and how to memorize anatomy terms or something. Like they wanted like a book that was, that showed that I read something outside of, I guess, medicine. And then I said that I would actually be accepted 3rd into the PA program, and they still took me. So, because at the time, one of the 2 girls, one was married and had relocated her family already for this, and the other one had small children. So we figured, well, it would make most sense for her, to not have to put her life on hold with kids, to do it while the timing worked. So I don't know. I think they were probably just looking for problem solving and strategy in there. I'm not sure. So yeah, I don't know if that helps, but those were the questions that I remember. It's weird that you remember these things, right? 12 years, what would that be? 13, 14 years ago?
So another question is, did your program require the GRE?
I think it did. I took it. So I remember I submitted it. So
what tips do you have, tips or recommendations for studying?
I didn't study. I just took it. I don't know that I have great tips. But I literally was just done with, I had just finished, and I don't know, a lot of the things that they had on there were classes that or at least subjects that I felt very comfortable and confident in doing well. And I did very well, the GRE. So I wasn't, awesome. I wasn't really worried. I don't know. It didn't so much matter. It's just that I needed to have I think a score above 60 or 70. And I thought, okay, well, yeah. I don't think I need to study to do that. So I'm sorry, I don't have a good tip there.
Well, her final question is, what additional certifications do you recommend getting before entering PA school?
I think it depends on your interests or your passions. You don't really need any additional certifications. I mean, if you want to grab ACLS and, BLS, that'll give you some opportunities to work in healthcare areas that you might otherwise not. But I would encourage you to find something you enjoy doing, and whatever that is, if there's a certification needed for that, then pursue that certification. But if you could do something, where you don't necessarily need a certification, but it gives you that experience, that's totally fine. So I don't know that you need to limit yourself. I mean, some people work as, EMTs. I mean, this is probably going back a ways here, but I like literally hung scans, but before they actually had EMR4, like I would go and get all the scans and like hang them in the dark room where you'd like flip on the light so the radiologist could read the scans. So that was like my first exposure to x-rays and things. I don't think that's even a thing anymore, but I got to, yeah. So, I mean, you can find, and I was like, this is just interesting. I have no idea what these scans mean, but I wanted to learn. So I thought this would be a great, exposure to that. So, I mean, you can just find something that interests you, and that's totally fine.
Alrighty. So one student wants to know, what do you think about the possibility of more autonomy within the profession with the evolution of the PA career? And do you consider yourself working mostly autonomously?
I think I mostly work autonomously, and I feel comfortable with it, but I also think that it takes time to feel comfortable to be autonomous. So I think I've been fortunate in my role that I've worked with great supportive physician staffs, whether they're cardiologists or surgeons. And I think that early on, they were much more available for me. So that way, if I didn't know or I didn't feel comfortable or, there was something that I wasn't entirely certain how to tackle, that they were able to be there to help me. And I think that once the group that you work with is comfortable with your skill set and knows your capabilities, then you get a lot more free reign with what you can do. I imagine when you first started in the ED, they probably weren't saying, okay, you just go see all the complex people, and good luck and we're going to grab coffee or something, like they probably were available, so that way if you needed some help that you were there. But, now that you've been there for several years, you probably can handle most of the things that come in and need probably very little oversight to do most of what you do. And so I think it's a matter of, at least most in my group, allow you to practice to the upper level of your licensure and kind of do what you want to do. But also it's nice that if there is something that is like totally out of left field, I know I have somebody I can call if I want to. I personally like that. But I also know that there are some PAs that really enjoy I would say though that there's a lot of collaboration too, where, when we present these patients or decide if they're going to get a device or, what we're going to do, that we do a lot of, sharing about, here's my thoughts or here's what you think or, so I think that it's nice to have a blend of both, but I think it just, depends on your preference. Some people really like to kind of work hand in hand. And I know some PAs that they and their, physician round together, do everything together, and then they just kind of like tag team it, so there's no right or wrong way to have it set up as far as more or less autonomy. It kind of just depends on what you want or don't want. And that is neither right nor wrong. That is you.
Thank you for that. So student wants to know, how realistic is the lateral mobility for PAs? I work with one who says it's not as easy as people say because employers want PAs with experience in the field they're applying for, and the learning curve can be too steep to be worth it. It's a major draw to the profession, so I want to know if this was actually the case or not.
Via lateral transition, do you mean like switching within roles, or do you mean me switching from a PA to like an administrative role?
I think that it could be switching within roles if the student wants to apply that. But what about switching?
Sure.
Well, I'm not switching
roles.
Not switching within roles, within specialty.
I mean, I guess it maybe would depend on the hospital. I think at my institution, I think that having experience within that facility and knowing the EMR and the culture and the environment is a huge advantage. So I think that there's probably a preference, I would imagine, given to internal candidates that have had some experience and have worked in here and know how the system works and how you already do a lot of these things versus somebody who's coming outside of this healthcare environment and wouldn't know any of those things, wouldn't have those relationships built up. So I don't know that I've seen that at all. If anything, I think it gives you an advantage rather than a disadvantage, but maybe that isn't the case at other institutions. I've only worked at the same institution, my 11 years. So I can't speak to what it's like outside of this, but I haven't seen that at all.
All righty. Thank you. So it's 8 o'clock, guys. Sarah, is it okay that we ask just a few more questions, maybe two more questions? Thank you.
That's fine.
And you guys, I'm trying to get through all the questions, so just gonna ask Sarah a few more, okay? An interesting question a student had was, how has getting your MBA helped as a PA? Were you able to get more opportunities with that, with your MBA?
I think that it's allowed me to pursue projects that I wouldn't have necessarily thought of, or ventures outside of medicine that make more sense to me. And I think that I feel comfortable structuring businesses or organizing things that I wouldn't have otherwise felt like I had the skill set to be able to do prior to that. It also has given me an appreciation for how to make medicine effective and why we sometimes do the things we do, why we order, or even just like the costs that seep into medicine that I don't know that I had a full appreciation for. So I think it was very valuable for me, at least. I enjoyed it a lot. What was the other part of the question?
Did you get more opportunities?
Yes, I did. I think that there are other things that I certainly am currently doing because I pursued that. I think that some of that also has shifted a bit because of the need in patient care right now. So I'm transitioning a little bit back more to full time in LVAD. But then I have a lot of things that I do outside of work. I've also, I've been the president of an international, organization, and I've done a lot of other things. So, developing that structure or developing strategy to kind of lead and shape organizations, or how do you implement or build, how do you deal with, membership or marketing or all of these other pieces. And all these are medical societies, right? So I've done a lot of program development, for different societies and different organizations. And I think that it has given me a bit more insight into how to do that more effectively rather than kind of just doing it in a way that I think would be effective. I actually now have an infrastructure around which to build these things. So it's given me more confidence to be able to do those things, I think, effectively.
That's awesome. That's awesome and inspirational.
Oh, thanks.
All right, last question. Guys, this student wanted to know, you mentioned you didn't choose the profession until someone spoke to you about it. How did you navigate that aspect in writing your personal statement, if you remember?
Yes. I think I just talked about how I wanted to be in medicine, from as long as I could remember. I talked about the pieces of the PA program. I don't know that I said that I wanted to do med school and then, decided to go the PA route. I think I more so just talked about what I loved about the PA program and the flexibility and the opportunity to be able to practice patient care, to be able to do that sooner. I think I just talked about the things that I loved and not, well, this was my second choice. I don't think I phrased it in that way. I think I just said, here's, why I really find this career field to be appealing.
Exactly. I'm glad you said that, because that's what I say all the time. Even if you had like a different, major or whatever it was before PA school, just sticks to discussing PA.
Yeah, we had a religious studies major in my PA program. You don't necessarily have to have, a straight science background. I think that sometimes having a unique background or, different experiences can really bring a lot of value that somebody else may not bring. And maybe you'll be able to connect with a different group of patients or see things in a different way or bring novel experiences or be able to connect pieces differently than somebody else might. So I think that you should not discount yourself at all if you don't have, the standard background. If anything, it might be a unique advantage.
Yeah, that is very true. Mm-hmm. Okay, so I'm not gonna, bombard you with so many other questions, but that was about it, though. I think I went through just about all of them. Anything, just general PA questions, guys, I don't mind answering. But thank you so much, Sarah. Yeah. For sharing everything about LVAD. I'm sure you guys know a lot I did when I was in PA school, so yeah. You're not there yet, you know all about LVAD. So
we may be hiring by the time you guys graduate, so you never know.
Thank you so much for that, sharing your expertise, your journey. You're great, so inspirational, so knowledgeable. Thank you.
Yes, of course.
I know students are going to want to know, if they can, get in contact with you to ask you more questions, or is there any way for students to get in contact with you, LinkedIn or any social media, email, anything you'd like to share?
Yeah, I'm on LinkedIn. I don't check it all that often, but you certainly are welcome to send me a message on there if you want to. But if I don't reply, don't take it personally. I just feel like I know some people are very big into social media. My sister is a huge fan of that, but I just don't check it all that often. So I will eventually get back to you.
No problem. Yeah, and I'll definitely share it on Instagram and social media, guys. And I'll put mine in the meantime. So you guys, and when she does, let me know her LinkedIn, guys, and I'll let you guys know, because I'm sure they have a ton of questions for you.
Yeah.
Thank you so much, Sarah. Again.
Yes.
You're getting a ton of praise in the chat.
Oh, thank you. Good luck, everyone, in all of your, future endeavors.
Thank you. Have a good night. Get home safe, Sarah.
Okay, bye.
All right. Good night, guys. Bye, guys.